A 32-year-old Asian male presented with a productive cough, shortness of breath, and night sweats. I am showing you his initial chest radiograph. Describe the findings.
Okay, assessing the provided imaging. The chest radiograph shows consolidation in the medial segment of the right middle lobe. There are right hilar and right paratracheal nodular soft tissue density opacities consistent with lymphadenopathy. No pleural effusions are seen.
Excellent. What is your primary diagnosis?
Given the clinical history of productive cough and night sweats, along with consolidation and lymphadenopathy, the primary diagnosis is primary tuberculosis.
What are the key differentials for consolidation combined with lymphadenopathy?
The key differentials include tuberculosis, sarcoidosis, and lymphoma. Other infective organisms to consider are histoplasmosis, mycoplasma, and varicella.
How does the distribution and presentation of primary tuberculosis differ from post-primary tuberculosis in adults?
Primary tuberculosis typically affects the lower lobes, middle lobes, and the anterior segment of the upper lobes, and accounts for up to 34% of adult TB cases. Unlike post-primary TB, it frequently presents with parenchymal consolidation, pleural effusions, and unilateral hilar or paratracheal lymphadenopathy. Post-primary TB typically affects the apical and posterior segments of the upper lobes, manifesting with cavitation, fibrosis, empyema, and mycotomas, while adenopathy is not a major feature.
Let's look at the cross-sectional imaging. I am showing you two axial CT images of the chest, these axial CT images. Describe the findings and the specific nodule distribution.
So, as seen in this axial CT image, this scan, which demonstrates widespread centrilobular nodules giving a tree and bud appearance, we can see poorly defined centrilobular nodules. In the adjacent slice, this scan, there is clear sparing of the subpleural areas, with no nodules seen within 5 millimeters of the pleural surfaces or fissures.
What is the clinical significance and differential diagnosis for this tree and bud pattern on HRCT?
The centrilobular tree and bud pattern represents endobronchial spread of infection, which is highly characteristic of active pulmonary tuberculosis. Other differentials for centrilobular nodules include endobronchial metastases, allergic bronchopulmonary aspergillosis, obliterative bronchiolitis, and hypersensitivity pneumonitis.
Tuberculosis is a multi-system disorder that can disseminate hematogenously. Let's look at this pelvic radiograph, this hip radiograph. What features are demonstrated here?
As seen in this pelvic radiograph, this hip radiograph, there is marked erosion of the left femoral head with ankylosis of the hip joint, resulting in marked limb shortening. This demonstrates severe monoarticular tuberculous arthritis of the hip. Radiographic changes of loss of joint space, peripheral erosions, and juxta-articular osteoporosis are key features.
How would you manage this patient as a radiologist?
I would compare the chest radiograph with previous films to assess for new consolidation or adenopathy. I would communicate the findings immediately to the referring clinician, raising suspicion for active primary tuberculosis, and recommend placing the patient under immediate airborne isolation precautions. I would recommend urgent sputum collection for acid-fast bacilli, AFB smear, culture, and nucleic acid amplification testing, NADate gene expert. Additionally, I would recommend a contrast-enhanced chest CT to characterize the mediastinal lymphadenopathy, looking for characteristic central necrotic low attenuation with peripheral enhancement, and rule out complications such as bronchial compression or miliary spread. This must be followed by urgent notification to public health authorities and referral to infectious diseases or respiratory medicine.